as part of the 2020 Peer-to-Peer Global Interdisciplinary Summit, all the way from Asia. Dr. Shakibaie, welcome to our show. I'd like to do a quick introduction on you. Thank you for joining us.
Hello, dear Kianur. Thank you very much for invitation. I am very excited and very happy to be part of the GIS marathon webinars.
Well, thank you for joining us. As a quick introduction to our viewership, Dr. Shakibaie is a pioneer of implant surgery. He has developed new microsurgical techniques and instruments for oral implantology and jawbone reconstruction. Dr. Shakibaie heads the implant division of microdentistry community, Microvision. He has also studied in Germany, as I have, so I find his career there quite interesting. He graduated from Berlin Charité University and gained a passion for oral surgery during his doctorate thesis at his oral surgery department. He specialized in oral surgery at Berlin and Bonn University and earned a mastership in implantology at DGI in Germany. And if that's not enough, folks, he earned also a mastership in periodontology of DPG in Germany and specialization in oral microsurgery and microdentistry of Zeiss Dental Academy in Switzerland. So Dr. Shakibaie has a longer resume than I could read off today, but he is well known amongst different communities in microsurgery and also in minimally invasive procedures. With that said, Dr. Shakibaie, I'm going to go ahead and get you your presentation up so we can get started. And at the end of the session, we will be doing the Q&A. And anyone interested in actually earning CE is welcome to go to gi-summit.com for more information. The webinars are complimentary for CE. We have certain processes that have to be met. And with that said, thank you, and I'll have you go ahead and take away. Hang on here. All right, Dr. Shakibaie, please proceed.
Oh, thank you very much, dear Kianur. It's a great pleasure for me to be part of GIS webinars. And this is the first time we are doing this together. So I hope all the videos I have prepared for today's presentation will work out far away from California. The subject I have prepared for you today are new minimally invasive concepts in implantology using the optical magnification of microscope or the loop. So, but before starting with the main subject, let's have a look on this video. Nowadays, we are overloaded with new developments in dentistry. We have to take a lot of efforts and unlimited time together with our teams to integrate all these developments into our daily work and daily care. So actually, it has become very hard and very difficult for every one of us to implement all these new coming protocols to let our patients benefit from each of them. But why we do this all? What is the main goal of all these new treatment protocols that are coming up into the new dentistry? The main goal is to increase precision. But why do we want to increase precision? Because to today's topic that I was mentioning before, and this is that are new concepts, new minimally invasive concepts in implantology using the operating microscope. Just a brief introduction of myself. Kianur was so kind to mention some of the data. So I graduated at Berlin University in 1999, and 2003 I finished a specialization of oral surgery at Berlin and Bonn University. 2006 mastership implantology of German Society of Implantology. 2008 mastership perio at German Society of Periodontology. 2009 I became a specialist of microdentistry at Carl Zeiss Academy in Switzerland. And since 2006, I have been developing, publishing, and lecturing new microsurgical techniques and related instruments worldwide. Since 2013, I'm cooperating with Zeiss Dental Academy in Germany and in Switzerland. And in the framework of this activity, we are preparing and we are conducting courses and lectures worldwide. And since 2018, we have been starting cooperation, scientific and educational cooperation with Penn and Michigan in USA. So as said before, we have published several articles that all are related into use or utilization of microscope in minimally invasive implant surgery and jawbone reconstructions. Most of them are published by different magazines of quintessence. If you look into the literature, we see a clear tendency during the last 2 decades of articles that are related into minimally invasive procedures in all the fields of dentistry, and that shows a significant interest of our profession to become minimally traumatic for the patients. But when we look into implantology and minimally invasive implantology, we need certain fundamentals before start those procedures, before start providing those procedures to our patients. First of all is minimally invasive tooth extractions and all the protocols that are belonging into this field. And of course, socket and ridge preservation, implant microsurgery, and 3D analysis of the jaw. Implant microsurgery itself has needs certain conditions, and this is very important to understand that when we are talking about minimally invasive or minimally traumatic procedures, we are talking about a whole concept. It is not just about using some new instruments or buying a microscope and looking through the microscope, but furthermore, much more we need to understand that there are certain parts that we are bringing together to complete this concept into our daily practice. First of all, most important is the time. Once we have started those procedures, we have to reduce the number of our patients in order to provide, let me say, higher quality treatment into this less number of patients. Of course, we need also optical magnification, all the devices that are used in this field. We have to increase or train our skills, experience, assistance, and so on. So now let's have a look into our surgery in my clinic in Tehran. I just want you to have to get an impression from what we are doing every day and how we are preparing the patient, for example. And later on in the same video, you will see how we are taking our pictures and our movies with the camera that is connected into the microscope. The preparation of the room takes minimum 30 minutes, sometimes 45 minutes, and we have to take this time to be accurate with the preparation. So this is a surgery of a patient with microscopic sinus lift setup. This topic I will be talk about during today's session. And now here you see the camera that is connected to my ProErgo, Zeiss ProErgo. With this Sony camera, we are taking pictures and we are also taking videos. But you will note later on that those pictures are let me say almost perfectly adjusted, and the angulation of the camera is almost perfectly adjusted and much better compared to the situation that you are taking the pictures with the camera yourself with bloody hands and unsterile hands, or additional photographer is doing this. So that will be much more authentical during such a session. And the lady that is sitting at the camera, you see here, this is very important to see this. The lady here is correcting my position with the microscope in order or observe my position. Let me say that this is better to say observe my position all the time continuously, to have a perfectly adjusted photo and video documentation. Okay, let's move on. Nowadays, the modern microscopes and all the connection features, they makes us able to use this very important optical magnification device also in perio and implant surgery. But originally, microscopes were used or got the foot in the door of dentistry with endodontics, as we know. And the Penn University is very famous and is a big pioneer in this field of microscopic endodontics, especially Professor Kim. But with these new features, we are able to use it properly also in other fields of dentistry, for example, implantology and periodontology that we are talking about this today. And very important to see with those two pictures that the microscope makes us able to enjoy dentistry much more and to extend our active time as dentists for, I don't know, much more years. There are no exact publications about the extension of the working time of the dentist using such a device, but it is clear that we are sitting behind the microscope much more relaxed. We have much more relaxed eyes and body, especially shoulder and back muscles. So that increases the quality of our daily work that we are providing to the patients. So today I will talk about different indications in implant surgery that benefit from using the microscope and from this whole concept that I was describing before. So let's have a look into the details: minimally invasive tooth extraction, socket preservation, implant placement, soft tissue management, open sinus lift, bone grafting. You will see later on or in the following time clinical examples related to all these indications. So let's start with minimally invasive tooth extraction and socket preservation. I always like to begin with this old picture. This picture is over 8 years old, and that shows that I haven't seen this situation for minimum 8 years anymore. meaning extracting a tooth in conventional manner or in conventional technique which increases the risk of injuries and trauma of the alveolar ridge up to losing of whole pieces of the alveolar ridge. So nowadays we go like this and we act like this. So we have a case here, tooth number 6, lower jaw on the right side. You see we have at the starting point 3D bone resorption, and this tooth is unfortunately hopeless, and we have in addition a fracture of the segment of the lingual segment of the crown. So we have to take this tooth out. But old endo teeth, you know, they are very fragile and very dry, so it can become very difficult to remove those teeth, as you know better than me. And the key success in those minimally invasive tooth extractions is to separate the tooth in several pieces. And this kind of separation can be observed and can be controlled by the microscope, because we are looking into the socket perpendicularly. And after removing the tooth in such minimally invasive manner, as much as we can, we fill the socket with BioOS large granule size. This protocol I published first time in 2009, and that was the reason we published also the whole statistic of 100 patients. That was the reason to receive the German Periodontology Prize in 2010. So since that time, we have been publishing 4 more articles about this technique, and we have been operating, I don't know, maybe over 1,000 patients during the last decade, and controlling them over the time. So this is a very safe and very reliable method that I'm showing you today here. So we are filling the socket with large size granule BioOS, and we cover the BioOS with gelatin sponge. The name of this product is Stipro from. Oh, sorry, I'll go back. So here, the name of this product is Stipro. This is gelatin sponge from the company Kurazan. It's also a German company. And then we move on and close or fix the situation with 6 or 7 sutures, monofill sutures. Then we wait for 3.5 to 4 months. This is the situation after 3.5 months. I think the situation just before the surgical procedure of implant insertion, and as you see, the situation is not bad. I mean, according to the 0 line, as we were starting with, the situation is not bad, and this technique makes us able to insert the implant right in the correct angulation in the lower jaw. But we are facing a small invagination in the soft tissue, in the keratinized soft tissue, and that was a situation that we were expecting, because we knew that we had a marginal 3D bone loss before starting the tooth extraction. Of course, we have to pay attention to be minimally invasive in all the steps of our procedures. It means also at the time of implant insertion, we have to take care about the adjacent papilla, left and right, or mesially and distally. And when we are open the situation, we see the amount of the bone that we were expecting from the cone beam CT. That makes us able to set an implant 4.1 BLT Straumann in the correct position that we were preparing three-dimensionally before. And as the primary stability of the implant was 50 Newton centimeter, it allowed us to set the gingiva former in the same session, so transgingival healing. And I would like to ask you, if we had the audience here present, or it was a congress at this stage, I like to ask how the people expect the situation after 1 month. And this is the situation. I doubt we would end up better, or in a better clinical situation, providing the patient with immediate implantation or PET or some other alternative techniques. So with this clinical view, we changed to the vestibular aspect, and this is the vestibular situation at the time of implant insertion, and then the same surgery as we were inserting the gingiva former, and 3 months, almost 3 months later, when we are continuing the situation with taking the impression. But what about the materials that were used or we are using daily for socket preservation or for other augmentative techniques? Let's have a look into this case, but please consider this is only one small section of a whole full mouth treatment of this patient. So we just focus on the teeth number 2, 3 is missing, 2, 4, and 5. They are unfortunately hopeless, and we are going to extract them and to provide this patient to apply socket preservation with the same protocol shown before. So this is, of course, a part of a whole treatment of this patient, but with demonstration of this case, I want to show you how different the results of socket preservation can be when we are using different materials. So it is very important what material we are choosing or providing our patients for socket preservation. The same protocol with minimally invasive extraction. It means we just move the teeth in vertical direction, and we move on. This patient is one of the 10 patients participating in a clinical prospective study that we have ongoing right now. It is will be finished at the end of the year 2020 and will be prepared for publication. So we took certain parameters to observe or to control the changing process of the alveolar ridge after minimally invasive tooth extraction and applying socket preservation using 2 different bone substitute materials. So after minimally invasive extraction, we take certain measurements in the width and in the height of the alveolar ridge. Also very important, the situation or the 3-dimensional measurements of the keratinized gingiva. So then we move on, and all this documentation is very important to know that all the documentation is done with the operating microscope. So please keep this in mind. The middle alveole is filled with bio-ost large granule size, and the left and right are mesial and distal sockets. They are filled with cerabone of botiss. So these two materials are from the statistic most used material for bone augmentation, jaw bone augmentation in implant procedures worldwide. So again, the middle socket is filled with bios. Left and right are filled with Botis Cerabone. The coverage is the same as I have shown before. This is the coverage with gelatin sponge with Kurazan Stipro, and the fixation are the sutures that we used here are monofield 6-0 Serralone from Seraj Wissner from Germany. So this patient receives, I was asked in the last session, what are you doing with those patients in the meantime? So don't you provide them temporary solutions? Of course, we give them provisionals almost every time. Our provisionals are removable because we want to keep the access free to the situation or to the aspect beneath the temporaries. If there are any problems or we want to continue our documentation, it's very easy to take out the removable denture and to make photos. So this is very important here. You see, this is the situation 10 days later, 10 days after the operation, after socket preservation, 1 month later, 2 months, 3 months, and 4 months. Something is very remarkable here, and this is, again, the adjustment of the camera. We always try to be perpendicular on the ridge to have the possibility to be authentic and have the possibility to compare the different time stages of the patient in the recall period, and this is very important for research purposes. So please have a look here. The situation after 1 month, we see after 1 month the bio-os socket is almost closed. After 2 months is fully closed, but even after 4 months, the situation, the soft tissue situation, is still not stable enough, let me say, in the alveoles of Cerabone, and that lets us expect not fully remineralized bone on the surface when we are opening after 4 months to set the implants in the regions where we were using Cerabone from Botis, versus the situation or the alveole of bio-os that has closed after 2 months very reliably. So we are expecting fully remineralized bone situation even on the surface of the ridge, and this is very important for socket preservation. And beside that, this documentation shows us, and it is also repeated, it has repeated in the other patients, also in the other 9 patients that are participating in this study, that has shown that when we are using the Cerabone material, we have to wait too long to have the patient back for implant surgery. So the vertical or the vestibular aspect, you see here, this is the situation 1 month after the surgery and after insertion of the temporary, and this is 3 months later. Of course, we are expecting a little bit flattening of the papilla, but I think this is a good situation also in vestibular aspect. The view in the Combeam City shows us a very stable vertical and, or let me say, 3-dimensional situation or three-dimensional bone view you see here. And something is remarkable. We have here, I mean, the transition of the material to the bone tissue is very fluent, but here the transition is not that fluent. You can recognize here the border in the area of cerebone compared to the area of bios. In addition, we take the parameters of bone density, but this is only for research. And then we are going into the implant surgery itself after 4 months. I showed you that we were forced to wait 4 months because the soft tissue coverage was not stable enough in the alveoles filled with cerebone. So otherwise, if we were using only bios, we would set the implants 1 month earlier. Something else is notable in this documentation, and this is the design of my flap. It is very important to go for a split flap because the 2 millimeters, let me say, the material of 2 millimeters height of the ridge is sometimes sticking beneath, or sticking to the periosteum beneath the mucosa. So if you go for a full thickness flap, you are at risk to remove 2 or 3 millimeters from the surface of the ridge that can influence or impact the depth of your implant insertion and also your prosthetic planning. So it is very important to split, as you see here we are doing, to split the flap like here. And of course, we could insert the implants a little bit more minimally invasively with doing or providing the patient only very small single flaps, preserving the papilla at this stage. But we informed the patients, and they gave us their consent that we were able to do such a flap design and to have the free visual control on the situation of the ridge. This is why we applied the flap design like this. So, and this is a very good picture. You see here we have a full mineralized bony situation in the middle alveole compared to the situation mesially and distally. This is the bone is still not fully mineralized, and it is a little bit soft up to a depth of 3 millimeters. So this is very important. When you drill in those sites, your drills should be sharp and new. Don't use old drills that tend to vibrate, because you risk to fracture or to damage this soft ridge. It's very important. But something else is very remarkable here, and this is the outline of our ridge. The outline is straight, just like the neighboring teeth, meaning this technique is preserving the ridge in three-dimensional situation, and it doesn't allow the ridge to fall in and to resorb. The implant insertion, of course, must be three-dimensionally if you want to be on this level of surgical quality or precision. We have, of course, to prepare every patient three-dimensionally. And I can give you another tip here. You see, we always open our splints or 3D splints to vestibular, so that we have free view on the ridge we are operating on. This is very important sometime, because if you close the splint, you have always blood beneath it, and you are not able to check the bony situation, and sometimes is disturbing you as surgeon. So this is a very good tip. We just use the splint for the primary, for the first drill, and then we move on with the further drills without the splint. So, and the depth, of course, we have the indicator on the drills. Implant placement and soft tissue management. Optical magnification is playing a crucial role for manipulations on the soft tissue, especially around the implants. That is coming into the focus of research increasingly in the last 10 years. Imagine you are working, or you are applying surgical manipulation on such a patient. This is a case where we planned to make some manipulation on the thickness of the gingiva at the time of tooth extraction. So this is also a very small part of a whole a full mouth treatment. But you see here, this mobile tissue is very, very thin. And if you don't have the visual control, you risk to perforate the covering mucosa very early, and to influence the outcome of your surgery in a bad way. So this is a very good support and help in those situations, to use microsurgery with visual control of the optical microscope itself. Let's have a look into this case that underlines how minimally invasive procedures and optical magnification can help us to apply to provide the patient the best possible surgical outcome in implant surgery. So in this case, we have we extracted the tooth 3 months ago with the same protocol of socket preservation that I demonstrated before. And now is the patient coming back with his removable temporary, supporting our papilla. Yeah, she had a removable temporary. And this is the situation. I think also at this stage, I tend to ask the audience, what would they do? So we have several points to consider clinically, to consider in this case. First of all, we have a very slight invagination. Sorry, show you here, a very slight invagination. Then we have deeply inserting frenulum. But beside that, I think the situation is very good, and that is also the CBCT proves it also in three-dimensional view. The situation is very suitable for the implant insertion. And then we move on with the surgery itself. You will see in the next cases that I am a big fan of rolling flap. So this rolling flap has been presented by different authors during the last 15 years, especially by Markus Hössler, Otto Suhr, but unfortunately there is still no prospective study comparing the results of this split rolling flap with conventional implant exposure technique. About this, I will talk later on. But let's focus on this case. So very important again to spare the papilla mesially and distally, and design a very small flap with connection to vestibular. And we always try to remain in the fixed gingival zone and not to go into the mobile tissue with our incisions. So, of course, the epithelialization up to 3 millimeters in this region, and then we elevate the papilla into vestibular direction. So very small fixation to vestibular, just to keep the flap in place and to not to use the retractor. The retractor is, in my eyes, one of the most traumatic issues in implant surgery while holding the mucoperiosteum or the split flap on the vestibular aspect. Is very, very important to use those holding sutures for, especially or particularly for those small flaps. Even for big flaps, it's very important not to put pressure on those flaps to have the best possible outcome afterwards. So we set the implant in the previously three-dimensionally planned position, as you see here, and we have the situation. Again, the tip, use always almost new drills. The drills should be sharp as possible. Is very important, just to avoid vibration movements on this ridge that you have built up with socket preservation, because the bone situation or the bone nature is a little bit softer than normal. Then we roll the flap into the envelope that we have developed before, a very small envelope, and fix the situation with 6-0 sutures. Our goal is, this implant, by the way, is 3.3, 12 millimeters. So our goal is to provide the patient restitutio ad integrum. It means we want to come as close as possible to the nature situation that the patient had before the extraction of the tooth. So always the goal is restitutio ad integrum, and it should be the goal of course, of any medical or dentistry treatment procedure. So a small vestibuloplastic or vestibuloplasty to decrease the pressure or remove the pressure from pulling forces on the vestibular aspect. We have worked in 2 regions for this patient, one here, one implant here, and one implant here. I think the length of the implant was not 12, it was 14. This the below one is 12. So this is the situation 6 weeks later after implant insertion. The implant is again transgingival. We chose the transgingival healing mode or modus because of the high achieved primary stability of the implant. And the situation 6 weeks later is really not bad in my eyes, but it is still not perfect. We will push the tissue on the vestibular aspect for further 1 or 1.5 millimeters with the prosthetics into vestibular direction to receive the best possible aesthetic result. So this is at the time where we are taking the impression, and again, the aim or the goal of our treatment should be restitutio ad integrum, meaning even the ugulae alveolaris, we want to imitate the ugulae alveolaris like the adjacent piece. That goes, of course, also for more extended cases where we are applying different method or different surgical techniques without a split rolling flap. This is only, double door technique, dividing the portion of keratinized gingiva to vestibular and to oral, and also applying the vestibuloplasty. This patient is an old patient of us, and you see the situation of this patient 5 years ago as we were exposing the implants. This is the situation 1 year later, and right now he's coming back to 5 years recall that you see here. The 5 years recall, and all the implants in the upper jaw were inserted after socket preservation. I think the bone level after 5 years is very stable, and the below situation is after augmentation or grafting from ramus, left and right, autogenous bone grafting from ramus. Okay, let's have a look on open sinus lift. This is one of my favorite clinical and research fields that I have been publishing in it. So we started almost 15 years ago to think about new minimally invasive alternatives in open sinus lifting, and we end up with the development of a whole surgical set that is called sinus lift instruments for microscopically guided sinus elevation, or sinus lift. With other words, I receiving the note from Keanu that I have only 11 minutes remaining, so I will speed up a little bit to come to a conclusion. Okay, so I just want to show you a very difficult case that is, driving me crazy, to be honest. I had those cases in the last 15 years treating that are reserving all the techniques that you use for augmentation, like butter in the sun. You can augment and graft whatever you want. They resorb it, and this is one of these patients. Please note this is the situation before we start the sinus lift, and we have an arteria here in the crista zygomatico alveolaris. So this technique makes us able to minimize the trauma of those very difficult open sinus lift cases significantly. Of course, we have prepared the patient three-dimensionally, and this is the opening. After opening the flap, our plan was to insert 2 implants in this augmented area and to apply microscopic open sinus lifting in this area. So we move on. We set the first 2 implants. I was not that happy with these 2 implants because I had not that much bone width on the palatal aspect, but I think that was okay for this super compromised case, and then we move on with the surgery itself. I just want to give you an impression from how we can decrease the trauma of conventional sinus lifting that is provided to millions of patients worldwide by using these microscopic techniques with the new microsurgical instruments. So I just give you, because I have only 9 minutes remaining, so using this technique enables us to decrease the accidental perforation rate of the Schneideren membrane or the sinus lift membrane to a minimum. I mean, if we compare it to the literature, we have perforation rate between 10 and 30%. And using this technique enables you to decrease it to 1 or 2%. Sometimes you don't see perforations anymore because you are super precise and you are super careful, let me say, because you check, you move second for second on the visual control. So you start with the bore, with the bore diameter 0.2, and you prepare a window like a circle with a diameter of 4 millimeters, and then once you see the first blood vessels bleeding, supraosseous blood vessels bleeding, like here, the first blood vessels bleeding, this is the indicator for you to stop the bone preparation. At this time, you will have a very small and very thin bone layer remaining on the Schneideren membrane. That makes it possible to continue the operation or the surgery with breakage or with breaking, controlled breaking of this remaining bone layer. So you see, we have developed different instruments with different angulations, and there are certain features that we have added into the design of those instruments. First of all, we have changed the angulation of these instruments, because when you are sitting behind the microscope, you are not able to move your body like this, like making surgeries with unarmed eyes that we are doing. And this is the reason why working with microscope is very much more ergonomical than working with normal glasses or something like this. Okay, and then we have 10 different instruments with 10 different angulations. The angulations are adapted to the fixed body position behind the microscope. Then we have sharpened the ends of the instruments just to make you able to put less pressure when you are maneuvering or when you are moving in the sinus ground. Beside that, we have roughened the surface of all the instruments, just not to have, just to avoid uncontrolled light reflection into the eyes of the surgeon sitting behind the microscope, and much more. So with this difficult situation, and you have seen in the Scumbeam City, we had 2 arterials in the neighborhood, in the very near neighborhood of this window that you are preparing. It's only 4 millimeters in this very difficult case, and then we augment the median part, set the implant after augmenting the median part, because the implant stops us to have the access to the median part. And after setting the implant or inserting the implant, we continue with the rest of the augmentation, and with the instruments that are angled properly, we are able to reach any corner of the subantral space. Okay, so, and then I move on. This is the procedure of suturing. We bring first Firstly, we bring together the corresponding points of the flap, and then we move on with suturing in between of the main sutures. The main sutures are 5-0, and the additional or accessory sutures, let me say like we can say like this, are 6-0 or 7-0. This is the situation after 1 week. You know, I mean, the surgical procedure, we provided this patient with sinus lift and setting the implants and so on. It was almost 3 hours, but after 1 week, you have such a beautiful situation. The same patient on the left side. Most of the colleagues I have in my sitting in my workshops, they think once they have learned this technique, they will have no complications anymore. But this is the same patient on the other side. I mean, on the right side. Please note also here on the left side, very difficult situation and very advanced resorption. So you see here, the procedure is the same, always the same, but unfortunately, I have a perforation here. Unwanted accidental perforation. Once you have a perforation, you are forced to make the osteotomy bigger. I mean, to remove the bone around the perforation just to relax to elevate the membrane and relax the membrane to decrease the size of the perforation, and then to stick or to suture or to close it with the membrane. Yeah, but please have in mind there could be, or there can always be, those sharp edge bony islands, and they can decrease, they can enlarge your perforations. They are very dangerous. So without having microscope or microsurgical instruments, you would never be able to remove those bony islands with sharp edges to close the perforation, to continue the operation and to give the patient the sinus lift treatment. Okay. So please always have in mind, I will jump, I don't know how long I have, I will move faster to the next case. Sorry.
Doc, we got about 3 minutes before the next speaker.
3 minutes. I will conclude, just a moment. I will go back and conclude. This is a 1 hour lecture, actually. If you give me 5 minutes, I will go through the last case. Do I have 5 minutes?
Yeah, we can do 5 minutes.
Okay. So let's have a look, because I mentioned the importance of the implant exposure. So this is also one of the patients participating in our current study that we are writing the article on with Pennsylvania University. We have set 3 implants in this case. We have, please keep it in mind that these colorations or dark colorations are from amalgam tattoo. There's nothing, with nothing wrong with the soft tissue coverage. So we have 2 implants here and 1 implant here that we set 6 weeks, 2 months before. So we choose the patients according to the guidelines of the study, and they had to provide us the same keratinized soft tissue situation to include them into the study. But I will show you the design of the surgery of the flaps. So this is the vestibular rolling flap, and this is double door technique. Double door technique is very common, is mostly used by surgeons around the world, but we are comparing in 10 patients and 44 implant sites directly the effect of these two different surgeries. So this is very new. The first time that a study is comparing directly clinically those techniques. So we have rolled on this side. This is vestibularly rolled, and this is the double door technique, just opened, very conventionally to vestibular and to oral. And let's have a check. Of course, we have different parameters to measure. I don't want to talk about this. I just want to show you the development of one of the patients. So here we have the situation 10 days later. You see the situation here and the situation here. This is, uneventful healing. This is the situation almost 2 months later. And at each step we are taking the parameters. This is the situation 3 months later. You see here the soft tissue situation, and here we have a small collapse, and the thickness of the keratinized tissue is almost between 2 or 3 times. So we followed up these patients for almost 1.5 years, and we gave them two stages temporaries to form ideally emergence profiles. And this is the situation after 6 months after giving them the final restoration, which are Emax crowns with individually fabricated zirconia abutments. And this is the situation 1.5 years later after implant insertion. And you see there is a big difference between the vestibular split rolling flap and conventional double door technique. Of course, this is no bad clinical situation, and so many patients, they have this in this region 7, but region 6 will be much more stable in long term. So I want, we will publish this article soon with pen, but I want to motivate every one of you to have an eye on vestibular rolling flap. So with this, I want to come to my conclusion. Optical magnification changes the mind in dentistry. Of course, opens the door to minimally invasive treatments, is one of the main conditions, and minimally invasive dentistry is the future. We are providing courses worldwide. I will be done in less than 2 minutes. These are impressions from our last course in Istanbul in cooperation with Carl Zeiss Academy from Germany. So we will start those courses in cooperation with Carl Zeiss from 2021 in USA. If nothing comes in between, like Corona, I don't know what. And our last course was in Dubai, in cooperation with Zeiss, with Dentsply Sirona, with Quintessence Publishing, and Ustomed. So if you want to receive updates on our educational program and activities internationally, please keep in touch on Instagram and on Facebook. It will be my pleasure to meet you in our future events. Thank you very much. Thank you very much, Kianur, for giving me the platform today, and it was once again a great honor for me.
It was our great pleasure to have you, Dr. Shakibaie. What a wonderful lecture. I personally have many questions for you pertaining ergonomics for the microscope and the cases that you're doing. But we will have everyone post their questions down below, and please respond to them, as they will be on the Facebook page, Global Summits. And we look forward to working with you in the many years to come.
Thank you very much. My pleasure.
Thank you for your contribution also to this project and undertaking, as not only a regent, but also with your presentation. Have a wonderful day, and we'll be in touch.
Thank you very much. Goodbye. Take care.
Bye-bye.
Bye-bye.